I'm Dr. Kelly Casperson. I trained in Colorado, and it is a huge honor to be here with you today. I hadn't been back in 10 years since I came back last year, and I'm really happy to be here. So let's see it. Now I'm going to come every year, unless you think I get boring. My disclosures, I have a podcast. It's a passion of love, and we'll talk about more about that later. Sex makes people feel awkward. So if you feel awkward in this half an hour, you are normal. You are not broken. Sex is super awkward in our society. And if thoughts come up or judgments or feelings that come up during this, let them acknowledge that. There's a lot to learn from our judgments about sex. I generalize. I sometimes use heteronormative terms. I sometimes speak as if we're all in partnered dual heteronormative relationships. I know that that's not how the world works, and I want to say up front, I generalize, but I don't mean to exclude. We don't know anything about sex. If you were lucky, you got a disease and sex pregnancy prevention program before you were partnered, before you were having sex, likely with anybody besides yourself. And we did not get a good sex education in medical school. I was talking to my friend Ben, who we did residency for, and we were talking about the cadaver labs. And I'm like, do you remember dissecting the clitoris? No. We get things that were excluded in bodies. We got it excluded in med school. And sex is so wonderfully complex. Biopsychosocial. It is an amazing topic, and that's why I love to do it. So my objectives today is for you to never tell a woman in the clinic to just go drink a glass of wine. That's my objectives. If I accomplish that today, I have done a very good job. Sex is complicated. We can't fix everybody's sex problems in a 10-minute clinic visit, and I release the pressure on you to fix everything in one visit. You don't have to do it. We don't have a lot of sex ed, and patients are coming in horrifically undereducated. You don't have to fix it in one visit. Everybody has erectile tissue. The clitoris is actually just a little bit smaller than the penis, just a lot of it is buried. We did not learn about clitoral erectile bodies or structures. We didn't learn that the blood flow in all pelvises has to be aroused and engorged in order for pleasure to happen. But we all have the same body parts. It's just rearranged in a slightly different way. So I started learning, and I'll talk about my journey a little bit more in the podcasting session, but I started learning about sex ed, and I hated the word biopsychosocial because it sounded very PhD and it sounded very long. And I was doing a talk, and you needed like 3 key points, and I'm like, oh shit, it's biopsychosocial. And so now I love this word because it really does explain sex. Sex is not just your hormones. It is not just your religion. It is not just your relationship. Sex is wonderfully complex, but that doesn't mean it's complicated. So the medical world has broken up female sexual dysfunction or wellness or optimization, whatever you want to call it, into 4 different packets. Desire problems, arousal problems, orgasm problems, and pain problems. It's pretty much like any gender, right? You can have an issue with all of those. So I started learning about this, and you started learning about, we were going to talk about some medications for low sexual desire. And I was talking to like a world expert on this, and I'm like, yeah, well, what you're doing is you're assuming that everybody's not trying to eat mushy broccoli. You're assuming that the woman's sex that she's having is actually worth desiring. It's hard to fix a desire problem with a medication if you've got mushy broccoli on the menu and you're just trying to stuff mushy broccoli down somebody's throat. But it's very important because if a person comes in and they say, I have low sexual desire and I have pain, I'm like, no, you have one problem, you have pain. You're never gonna desire hitting your thumb with a hammer. I like to take problems away. I take interstitial cystitis diagnoses away. I take 2 problems with sex away from people because they don't want this heavy backpack on their shoulders. They like to not think they have so many problems. And I say, is the sex you're having, do you like it? Is it good? They're like, I could take it or leave it. And I'm like, okay, well, now you don't have a desire problem either because I can't make you desire mushy broccoli. So who's heard of the orgasm gap? Anybody heard of the orgasm gap? Not many people. The orgasm gap is the research done saying in a heterosexual couple, the female's rate of orgasm is horrifically lower than her male partner. This evens out in same-sex individuals. And it's not because women are more challenging, and it's not because women take longer, and it's not because the clitoris, we don't know where the clitoris is, but That's not it either. It's biologic explanations have been discredited. Sociocultural factors, the preference on one person's orgasm, is why the orgasm gap persists. The best case scenario for the heterosexual orgasm gap is a long-term loving committed relationship, because they care about her orgasm a lot more in that relationship. For anybody who has kids in college, the hookup culture orgasm gap is horrific. Female orgasm in the hookup culture is 13% to the man 77%. This is my in-laws' garage. They labeled their light switches, and I don't think they know what the G-spot otherwise means. So I went in there, I actually visited them, and I went in there. I've been waiting to take a picture of this, because I'm like, I'm gonna use this in every single one of my sex med talks. I'm like, I showed this to my husband, and I'm like, do you think they actually know what G-spot means? And he's like, no, not at all. There's this amazing paper that came out called The Heteronormative Theory of Low Sexual Desire in Women Partnered with Men. It's mind-blowing. And the women I introduce this to, if they come in and they're like, I have low desire. I'm like, well, did you know in heterosexual relationships, if you mother your partner, people you mother, you're not supposed to be sexually attracted to? Oh. Did you know if you do more work in the household, that lowers your sexual desire? They're like, oh. So a little bit of sex ed goes a long way. And the other point of this is I don't prescribe medications for people on the first date. Meaning I want them to understand their sexuality and the role that their lifestyle plays in their desire before I just say, here's some testosterone, here's some FDA-approved medications for this, here's some lube. Because if they fail that, because they have all of this going on, now they're a medication failure, and they feel even worse about it. If you're always the person who has to respond to your partner's advances for sex, that lowers your sexual desire, because you don't understand what actually makes you want to have sex. You're always responding to somebody else. So amazing paper about that. And everybody thinks that, like, if I just had desire for sex, I'll have an amazing sex life. If you ask the people who raise their hand and they're like, we have amazing sex. Debbie Herbanek researched them and wrote a book about it. Nowhere in there is spontaneous sexual desire an ingredient for an amazing sex life. And it's worth knowing, because everybody's like, I just want to desire sex. And I'm like, do you really? Do you remember what that was like in 11th grade? It's very distracting. So many people think they ought to feel sexual desire in the absence of sex worth wanting. Mushy broccoli. Freud messed it up for everybody. He said that desire is a natural instinct like eating and hunger. But unlike if you're thirsty, you just get more thirsty. If you don't have sex, you don't want more sex. It's not how it works for everybody. Then there's responsive desire, and a lot of people don't know that this is normal. You are busy, you're running a business, you're taking care of children, you are planning dinner, and then your partner's like, you want to have sex? And you're like, no, I was thinking about the election. And then you start getting into it and you start doing some things, you're like, no, sex is a really good time. If you have a great time in the bedroom, but you just don't want it all the time, you're completely normal. That's responsive desire. And I fix so many people who think they're broken just by explaining this. The FDA doesn't want to approve anything for libido. So they made up a term called hypoactive sexual desire disorder. This is a little bit different than responsive desire. Responsive desire is like, I was thinking about the election and I'm not in the mood, but like now I am, because I really like sex with you and like I have a good time and we've got pretty good orgasmic equality. Hypoactive sexual desire disorder is like, I used to love my sex life and I love my partner and I understand all of this sex ed that you just told me, but like there's no light switches that get switched anymore. It's just kind of gray and mushy. This is a neurotransmitter thing in the brain, and this is where the medications start coming in. So I always kind of do the education first, and I joke, I worked really, really hard to make my clinic super easy. Because I'm like, just read my book and just go to my podcast and like do a follow-up in a couple of weeks. So they can get their education. So when they come in, we have a much higher level of communication, and those resources are free for everybody else too. So this is the definition, medical term of hypoactive sexual desire disorder: lack of motivation for both spontaneous and responsive, and to participate in sexual activity. And this is real. If you look at the data, about 40% of people, women, will have low desire. About 11% of them will be distressed. Definition of this is it must be distressing. For a person to come in and be like, I just never really been sexual and I could kind of take it or leave it, and I'm like really okay with that, that's awesome, that's fine. We're not trying to make anybody have like what Hollywood says your sex life should be like. So you have to be distressed by this. It's impacting my relationship. I used to be sexual and I miss it. I want. It's distressing. So first line, desire arousal treatments, use lube. Like, it's amazing what a little bit of oil-based lubrication can do for your day. And a lot of people, the stigma around using lube, like if there was a drug that made you orgasm 80% easier, like Pfizer would have been on that yesterday. And it's called lube. So use it. The big heteronormative myth about this is women saying, my male partner told me I shouldn't need lube, or he said I'm not turned on if I'm not wet enough. Like, men really put this like wetness on women as a marker of interest in sex, and they're oftentimes not related. So use lube, educate on that. There are some over-the-counter supplements that increase blood flow for desire and for arousal. In no particular order, these are just some of the things on the market. There is more and more in the published research about vibrators now. If you've never met a person and they're in your office complaining about sexual issues, don't just tell them to get a vibrator. Like, it comes across a little crass. But from a medical term, like blood flow to the pelvis tells the brain in the pelvis, I want sexual activity to happen. Your pelvis is otherwise like, what is this? Is this a tampon? Like, what do you want me to do down here? You've got to let the pelvis know what the activities are going to be. And there is more and more data, again, on the power of vibration. I always joke that I have 2 vibrators for my mouth. I have an electric toothbrush and I have a water pick, and they've changed my life. And we shouldn't exclude technology in only one department. So what about testosterone? We can do an entire talk on testosterone, especially female testosterone, and the problems with the United States and the gender bias on this hormone. First of all, who learned in medical school that testosterone's in every body? Good medical school. God, I did not learn that. Who learned in medical school that women have 4 times the amount of testosterone in their body than estrogen? Right? Who knows that if you go to Google and says, if you type into Google, what's testosterone? It says it's the male hormone. Google is wrong. When Google is wrong, we've got a problem. So all bodies have erectile tissue. All bodies make testosterone. Women do this. I actually did it. I drew my testosterone and estrogen, and then you have to convert the units because they're made in different units. And then you're like, there it is. My testosterone's higher than my estrogen. No, I didn't know that. So testosterone is the most studied. Low libido is the most studied indication for testosterone in women, and I'm happy to teach anybody how to do that. We're urologists. We're comfortable with testosterone. We give 10 times the testosterone dose to males all the time. It's very easy to do. We do not have an FDA-approved female dose testosterone in this country. It is coming probably about 3 to 4 years from now. The indication will be low libido, which is a sign of hypogonadism. But in men, it's approved for hypogonadism. It'd be nice to see gender equality there. But in women, it's going to get approved for us not wanting to sleep with other people. Disagree with that being the only indication for testosterone, but it does work. We have a lot of data. Why do we have more data for desire in women and testosterone than other things? Because the FDA said, we're going to approve this for low desire, so that's what we need the data for. So the tail kind of wags the dog on like, we don't have data for testosterone for other things. Well, because the FDA said they were going to approve it for low desire, so that's what they researched. There are clinical guidelines available. There's a global consensus on how to do this, translated into over 14 languages. We don't have a global consensus on hardly anything in this world. We have one on women and testosterone. So this is for you guys to study later of testosterone and the guidelines. Sharon Parrish is an amazing internal medicine doc who was the first name on the international guidelines for this. Pellets have given hormones and testosterone for women a very bad name in this country. It is very hard to give women a very high dose of testosterone when you use the transdermals. It's also very cheap. You shouldn't have to remortgage your house for hormones in this country. So this is how you do it. You take a male product and you make it last 10 days. I like the screw top gel because you can put the screw top back on and air doesn't get in there and affect the gel quality. Also, it's very hard to, how do you dose 1/10 of a ketchup packet? It's very hard to do. So the twist off is much easier. You can also compound it. It's very easy to compound. But if you take a 30-day supply and you divide it by 10, it's a 300-day supply. So it's pretty darn cheap to do the transdermals for women. So there are 2 medications that are FDA approved for hypoactive sexual desire in women. The barriers to get this through the FDA was insane compared to Viagra, which we've had since 1998. Addie's flibanserin, this is a daily medication. You take it at night. Side effects include better sleep and slight weight loss. Does not work in everybody, but in the people who it works in, it is life-changing, is what they say. I'm loving sex life again. I'm actually interested. I'm having sex dreams. This is fun. Thank you very much. Here you go. It is brand name, so flibanserin's the generic, but it's not, you're gonna be your low-cost option. Neither of these are. PhilRx, to my knowledge, is the only, they work through one pharmacy to get it. You can't get this at Walgreens or Walmart. But getting insurance to approve it is actually pretty nice. I have not had huge problems with it. Or you just say, you know what, try cash for a couple of months. Sometimes you do have to be on this 2 or 3 months for it to work to see if you respond, to see if it's worth your while. Vyleesi is the other one. This is an injectable, so this is on demand, 45 minutes before sexual activity. Does take longer in some people. There's some reports of like waking up 4 hours later and being like, I'm ready. So you might not know how long it takes for some people. Nausea, so they do recommend prescribing Zofran or ondansetron with it. I tried it because I was curious. I had a horrific hacking cough. So I was like, that's not sexy. So I'll try it again. And I had a horrific hacking cough is like 2%. I was like a 2% side effect. But I'm like, should I list this under my allergies? I'm not going to. But for people who don't want to take a daily pill and want an on-demand, it's nice. It's like a diabetic needle. It's very small. It doesn't hurt. I think I broke your mouse. Here we go. Does estrogen help desire? Testosterone is the thing that gets all the play for desire. Estrogen helps desire. Sometimes you just throw a freaking estrogen patch on people and they're like, oh my God, maybe I didn't want a divorce. Maybe I just needed an estrogen patch. Estrogen's very, very good for desire. It just doesn't get the playtime that testosterone gets. Top 2 reasons that women stop being sexually active in midlife. Number 1, availability of partner. Number 2, vasomotor symptoms of menopause. I always joke, I can't help you with the first problem. But if I fix your sleep and you feel like yourself again, sex might become more interesting to you. But there are some studies that say estrogen doesn't do everything. Same with testosterone. None of this works for everybody. Does Viagra work? Well, it's a vasodilator. It's nitric oxide. We know we all have the same body parts, just in different rearrangements. It increases blood flow. Doesn't work in all women. Some women are like, I want to have sex. I don't have blood flow. I have blood flow. I don't have sex. So this non-concordance, it's not as like 6-inch light switch that some genders have. But we do have some data. I think we're using this more and more for a couple of reasons. Number 1, interest in female sexual dysfunction. Number 2, it's really cheap now. And we do have some data in type 1 diabetes, antidepressant-associated arousal dysfunction. 80% of people on antidepressants have some sort of sexual dysfunction. How many people are actually given that informed consent? Blunted orgasm, this is where everything gets off-label. We need tons of more research. ISHWISH, which is the International Society for the Study of Women's Sexual Health, is going to come out with orgasm guidelines, but they're not there yet. Addie, or flibanserin, does help orgasm. We actually have data in men for this too. What percentage of a pink pill that is FDA approved just for women for low desire is taken by men? 10%. They labeled it pink. They said it's only for women, and 1 in 10 people who take it is male. It helps them too. So you have a busy woman, she comes in, she says, man, my job is really rough, and now I've got my partner pestering me, and I feel super broken. and I was listening to this podcast and I want to try a medication. I wouldn't do medications first in this person. I would validate her feelings. I would validate her experience. And I would say, it's okay to not want sex all the time. It's okay to learn how to talk about this with your partner. So what he needs and what you need can be on the same page. Women just want to be heard. And that is the cheapest and most important thing that you can do for these people. Pain. If you don't help pain, you're never going to love sex. There's a lot of things that can happen with pain. A good pelvic floor exam is absolutely necessary. ISHWSH has guidelines for sources of clitoral pain, but I'm going to move fast now because I need to talk to you about GSM. That's a clitoris and that's a penis. Clitorises get phimosis. If you take down their phimosis, their orgasm gets better and their pain can go away. Rachel Rubin has done a lot of publication on that. It's awesome.